an absolutely huge welcome to everyone today. Thank you so much for joining us with this first ever session as part of the international conference focused on maternity, early years, children and young people. We're absolutely delighted to see you all today. We're going to be using Slido, which Paul will introduce in the chat, to really understand some of the learning that's taken place today. And I've mentioned earlier, please do use the chat box for questions, which we'll pull together for the actual Q&A at the end. My job is to very succinctly introduce the maternity and early years section. So without further ado, I will move forward. So in 2008, the Cheshire and Merseyside Healthcare Partnership and the National Maternity Vanguard for the NHS, Improving Me, launched a social prescribing concordat for creative health for women and children as part of the NHS 70th birthday celebrations. This concordat was completely predicated on working across traditional silos, organisational boundaries, and it was all about collaboration. Most importantly, it was focused on addressing health inequalities, much of which Andy touched on earlier, not least in 2008, the actual backward steps for life expectancy for women that were experienced across the north. So today's a bit like coming home for me. It's quite simple, really, why we need to focus on maternity, but it's often not articulated. For me, there's no period of time that's more important for human growth and development than the first 3 years from 0 to 3. The first 36 months of life is when 80% of brain development is in place and all the critical foundations for future growth and development occur. But as a nation and across the developed world, we so often neglect the critical investment for this period. And language skills, social skills, the pointing and grasping and walking all occur and are so important for those very next steps in terms of human growth and development. But it's all dependent on a healthy and safe pregnancy and delivery. In short, it's one of the most critical investments a community can make, ensuring women and children are safe. But we have failed consistently to make that critical investment, and social prescribing is a way of starting to address that balance. Stress in the womb switches on and off key genes, we know from lots of the research, and that creates the disease and issues that we face today in terms of health inequalities and the conditions in which people live, diseases that people develop as a result of cortisol levels in the womb. It's a really, really challenging scenario, but social prescribing can potentially address it all. And as Andy Burnham-Agdeed said earlier, we can only do that by working together across those traditional organisations. Once a child is born, the brain is an unfinished project, so any investment then is absolutely crucial. But that investment needs to happen across the life course, and all our children need investment, so our teenagers too. I'd like to then therefore introduce Paul, who'll talk a bit more about the social prescribing focus for our young people and adolescents.
Thank you, Jo, and thank you all for joining our workshop this morning, and thank you also for staying muted. There's so many of us here, so that's much appreciated. So please do use the chat box to put your questions, and we will field those. The panel members will field those at the end of the 5 presentations that we've got for you this morning. So do put any questions that you have as we go through the presentations in the chat box, and we will pick them up at the end when the panel members will come and join us live for that last 20 minutes or so. So I'm Paul Jarvis-Beesley. I'm Head of Health at Street Games and one of the founders of the Social Prescribing Youth Network. So children and young people social prescribing, I think it's fair to say, is in the shade of adult social prescribing, but having a fantastic time ruffling around in the undergrowth down there. It's really exciting. I'm very upbeat about the current state of children and young people social prescribing and also about its potential. So we know young people up to the age of 25 have been the hardest hit by lockdown measures, and in our most disadvantaged areas, things were pretty tough before we even came into the pandemic. So in the last 10 years, public and voluntary sector youth services, we know, have been cut to the tune of nearly £1 billion, and levels of loneliness are higher in the 16 to 25 age group than any other. We're going to hear more about that today from our wonderful presenters. So there's a big issue there to be sorted, but I'm really upbeat by how the community and the health sector and others are responding to those needs. And it's emerged during difficult times, children, young people, social prescribing, and it's proving its worth. It's working on social issues, so it's helping children and young people stay engaged at school. It's helping them into their first jobs. It's keeping them safely off the streets. But it's also increasing well-being and physical activity. And you're going to hear some of the evidence, the early evidence about that from our presenters today. And then from our invited experts who are going to be telling you all about some of those things that we learned. But it is early days. The evidence is building. But I don't think that should deter us as pioneers from doing what we know is right for our young people. We need to get on with it and let the evidence build as we go. But let's not wait for the evidence, because in fact, without our activity, there wouldn't be any evidence. So we just need to crack on with it. So I hope you join me in feeling upbeat about this and upbeat about what is yet to come. Do use the chat box, as I say. And thank you for answering the first Slido question. There's 32 answers in there now. So if you scroll up the chat box, you'll see that question in there. And there will be others as we go. So please continue to use the chat box. I'm going to pass back to Jo to introduce our first speaker.
So a really short introduction to what can only be described as an absolutely fabulous project that is now international. Developed in Carnegie Hall in New York, the Lullaby Project pairs artists with mums and mums-to-be to create very personal lullabies and perform them. It's absolutely transformational, and it's making a huge difference and provides really key information about the value of music to impact on children's development and the relationships between mums. So over to the experts really to share more.
Thank you all for having us. Thank you to the co-chairs Jo Ward and Paul Jarvis-Beesley for inviting us to present on the Lullaby Project. My name is Tiffany Ortiz, and I am the Director of Early Childhood Programs at Carnegie Hall. And I want to share a little bit about the Lullaby Project, which is a program that pairs families with professional musicians to write, sing, and record personal lullabies for their children. These songs are opportunities for families to share their hopes, their dreams, their wishes, and their love for their children. And it's also an avenue to share their stories, their language, and their culture. So the Lullaby Project takes place in a range of community settings. It began in New York City and now runs globally in partnership with 40 organizations around the world, primarily taking place in healthcare settings, high schools, foster care, homeless shelters, correctional facilities, refugee camps, and other community centers. And the goal of the program is really to support parent well-being, the connection between parent and child, as well as the development of the early years of a child, and really also thinking about community building, how parents can connect with one another, with their community centers and staff. And we really wanted to find out whether this program was working. How do we know that it really does impact the communities that we're serving, which are primarily communities that are impacted by social inequalities, like disparities in healthcare and racism. So we worked very closely with Dennie Palmer-Wolf and her team at Wolf Brown to assess the impact of the program. And I will turn it over to Dennie, who will share more about those findings.
Thanks so much, Tiffany, and thank you for hosting us as a part of this very important discussion about social prescribing. We wanted to touch on what are some of the early findings from our work on Lullaby. So to be very clear, there is a body of work which suggests that music may be a very important resource and strategy for young families in formation. We know this from work in neonatal units, from work, for instance, of Daisy Fancourt around postpartum depression, and other work that uses music to engage otherwise absent fathers in childcare. So building on that, we've worked, as Tiffany said, with families in New York, and begun some observational and self-report findings, which tell us right away that parents, particularly mothers participating in this, experience sharp rises in their own sense of positive well-being and development. And secondly, that they also report sharp rises in the building of social networks that connect them to people from whom the pandemic and other circumstance has separated them. So in a new Philadelphia-based Lullaby, we also know that even in the current pandemic implementation, we can offer this program to families living in difficult circumstances, isolated by the pandemic. And we see that the uptake and persistence data is really quite striking. So 82% of families stay on for at least 7 of the 8 sessions. Almost 3/4 of them report using music more often to interact with their children, and 100% of them report, again, these same kinds of increasing social connections with people from whom they're separated from. Right now, we're working also to expand the kinds of things we're looking at by observing childcare, child giver and child interactions in free play during Lullaby, and looking at the experience of communication, especially language development, and also the possibility that experiences like this introduce play and delight in family circumstances which may be otherwise difficult. So just to look at the data, you can see here, families report new and stronger connections to at least 4 groups: their partners or fathers, other family members, other mothers in the group, and their own children. And then the positive well-being data, although self-report and descriptive still at this moment, shows you in the orange bars the very marked increase that mothers report in different aspects, particularly positive emotion and a sense of stronger relationships as they participate in a Lullaby session. And what we hope to do with this work is to continue the conversation, maybe even the collaboration with you in developing these measures and stronger and more robust evidence for the impact of this kind of activity and its potential role in social prescribing.
So we look forward to your many questions about this program. If you'd like to be in touch with Dennie or me, you can reach us at the email on the screen, and we look forward to speaking with you more. Thank you again for having us.
Thank you, Dennie and Tiffany. So some insight into an amazing programme that has been trailblazing for over 10 years with a substantial evidence base. I mentioned briefly we're producing a resource sheet which you'll all be able to access, so you'll be able to get more information on today's presenters. Without further ado, I'd like to introduce Celia Suppiah, who will be talking about Parents First, which is a community parent-led programme which is making a real difference to children and families' lives. Thank you.
Thanks, Joe. I'm just going to bring that film just to say the first 2 or 3 seconds of this film are silent, so don't worry about your sound controls.
Parents are the most important people in children's lives. In our communities, we have the most amazing, skilled parents who've often been through incredible life experiences themselves. they are in an absolutely unique position to support other parents within their own communities. We carefully recruit them for particular skills. We provide really good training and regular supervision. So here, Ganya talks about how her community parent really helped her through such a difficult time after having multiple miscarriages and being really, really scared and anxious about her pregnancy.
You know, she lets me talk. I think she listens to me. It's just like whatever I have as a worry, and thank God she's a mom as well. So whatever I have that I feel I'm not sure about, I ask her more. In fact, I ask her more than I asked my health visitor, I think.
These initiatives really are demonstrating social prescribing principles in practice. They enable parents to build their own social connections and support each other in the community. Skilled volunteers help them to navigate services and link them in with other VCS support. One-to-one support enables them to set goals and gives them that real personal support, that enabling them to find their own way forward. And lots of group support situations can help parents, especially when they are perhaps nervous and not feeling confident enough to access a group for the first time. These are really amazing strengths within our local communities.
It was really hard for me. It's my first baby, no family here, no mom and dad, no my husband here. So I was depressed, low mood, but Debbie, she really helped me. Because this pandemic, this virus going on, I was feeling very lonely. When Debbie contacted me, I feel like she is my family and I can speak to her anything.
I was very good at hiding my emotions. I was very good at getting on with things, putting my mask on in the morning and putting the act on and being the brave wife that gets on with everything. But Debbie knew that weren't right. So yeah, I don't think without having Debbie there, I don't think I would have, especially with lockdown and COVID and everything else, I don't think I would have coped or come as far as what I have now. Debbie was my lifeline at the end of the day.
I know it's actually a pioneering project, and I love to be part of things like that, like changing the way things are, because obviously there's a lot of lack for this kind of, especially community in a big city like this. Community is something almost, I would say, people crave for these days, but it's hard to find because we all live quite, like most of people don't even know their neighbors anymore these days. So I think there is great potential in this area.
The evidence really backs up peer support and shows that it's, really effective, more effective than a lot of kind of clinical treatments, especially for reducing stress, which has massive impacts, not just in pregnancy, reducing preterm birth, increasing birth weight, but also for, reducing postnatal depression, long-term outcomes with things like, bonds between mothers and child, and, the birth weight impacts health right through adult life. So it's really important, and, the NHS doesn't have the capacity to offer that at the moment. So I think it's a really important gap that needs filling.
pandemic affecting new mums who've been incredibly isolated. Our next speaker, Professor Pamela Qualter, has been at the forefront of understanding what's happening in relation to loneliness. Her work around one of the biggest ever research projects around the experience of loneliness with the BBC a few years ago proved a huge myth buster, in that we all make the assumption it's older people, but basically it impacts on our children and young people quite significantly. Pamela's going to tell you a bit about her research.
Hi everyone. First, I just want to say thanks ever so much for inviting me to give a talk today. I'm going to be talking about social prescribing for children and adolescents that are experiencing loneliness. I'm Pam Qualter. I'm based at the Manchester Institute of Education at the University of Manchester. So first, what do we mean by loneliness? Well, the need to belong is really powerful, such that when we feel it, we feel threatened. And we feel sad, we feel this whole set of different negative emotions. We can be angry, we can be sad, certainly frustrated. And really that happens when there's a discrepancy between the social relationships that we have and those that we want. Now it can be both in quantitative and qualitative terms. So it might be a case that I want more friends, but it also might be a case that I want better quality relationships with others. So I might want more of a trusting, close friendship with somebody, for example. But the idea is that when we feel these aversive, very uncomfortable negative feelings, what we're doing is we're motivated then to decrease those negative emotions and reconnect. The issue, though, is that for some people, they get stuck in a loop. So we have to be thinking about most individuals will overcome loneliness to reconnect, but there are some people that kind of get stuck. And they might get stuck because of lack of resources to reconnect and engage with others, or it might be a case that they become anxious and need help with dealing with that. But it might also be that they withdraw so much because of fear of reconnection. Now, loneliness can affect people across the lifespan. It isn't something that is is something that is felt by one particular age group over another. And actually what we find is that 5% of adults in England report feeling lonely often or always. And when we have a look at adolescents, we find from the ONS study, the same study, we find 11% of 10 to 15-year-olds report feeling lonely often or always. And in our own work, where we've used other population-based surveys, we find something comparable. So in one study where we used the Millennium cohort data, we found 10% of 14-year-olds in the UK reported feeling lonely often or always. And using the HBSC data from England, we found 8% of adolescents between the ages of 11 and 15. So this appears to be a problem across the lifespan. There's not one particular age group that experiences a lot. What quite a lot of the research suggests, though, is that we've kind of got these two peaks in loneliness, both during adolescent years and also during old age. Now, the UK government set out its vision in 2018, and they wanted to address loneliness. They created the 2018 strategy, and it advocated interagency working across different sectors. And they talked about locally developing tailored solutions for individual needs. And they increased referral to social prescribing schemes. Some of those ideas about particularly community-based work came about from a series of findings suggested that loneliness was particularly a problem for those with low socioeconomic status, so low incomes. And that seems to be the case for older adults and also for younger people as well. So whilst loneliness might be quite a common experience for those two age groups, if you are experiencing poverty, the likelihood of you experiencing loneliness is increased. But does social prescribing work? for those that report loneliness? Well, there are social prescribing interventions that have been developed specifically based on the government's 2018 strategy. To the British Red Cross, funded by the Carter Foundation, developing a national social prescribing programme aimed at supporting people at risk of or experiencing currently loneliness. And the idea was that they were going to reconnect with their communities. However, we find that to date there have been no published studies with loneliness as the primary outcome. So we haven't got any published work that looks at post-social prescribing where loneliness is the key target for intervention. So we haven't established whether social prescribing can actually make a measurable difference for people who are experiencing loneliness. So we don't know the impact. We also don't know the cost effectiveness of social prescribing for loneliness. Now, social prescribing, as I say, was part of that 2018 loneliness strategy. Patients could be connected to groups or services in their community. The problem, this is an additional problem when we're thinking about adolescents and children that are wanting, lonely children that we are wanting to actually engage or re-engage with communities, is that social prescribing often works via the GP. And of course, it's children and adolescents' parents that will have that relationship with a GP. Rather than the children themselves. So we've got an additional issue there about access to social prescribing in the first place, but we certainly don't have any evidence available to us in published work for whether social prescribing for those that are reporting loneliness is effective or not. Okay, I'm going to finish there. There may be questions. I'm excited to hear from people of their thoughts. Yeah, so thanks very much.
Okay, so with no more ado, I'm going to introduce Dr. Marcello Bertotti, he's from the Institute of Connected Communities. I know Marcello very well, and he's going to produce a lovely presentation for you, which is a very short snapshot of a brilliant evaluation he's done of a 3-year youth social prescribing pilot that took place in 4 English sites. So I am going to attempt to share the correct screen with the correct amount of volume and pass this over to Marcello.
Thank you very much for inviting me to present the results of this evaluation, especially to the chair and Joe Ward and Paul Jarvis-Beesley, and also to thanks to all the people who have helped to put together this evaluation, from link workers to colleagues at University of East London. I'll take you through quickly about the aims and the method. So the evaluation really took place in Sheffield, Luton and Brighton. And the model used, social prescribing model used there was a variety of referral sources. So the GP sent referrals to schools, who would refer young people to link workers in all sites, and link workers would spend about 4 to 5 sessions with young people, and in many cases they would provide outreach as well. And once the link workers and young people were agreed on the needs and aspirations, the young people would be referred to voluntary sector activities, physical activity, but many others, including, for example, young carers. So we did an evaluation looking at health outcome, social outcome over a period of 6 months, and a process evaluation, and also an economic evaluation, but I won't present the results now. So in terms of the demographic profile of respondents, the responses were aged between 11 and 25, and the gender was a good balance, unlike the social prescribing for adults scheme, which is mainly used by women, about 75% on average. And the ethnicity was mainly white British, so about 74% of respondents were from white British. The key results, there are many results to be honest, but I only have time to present these few. Personal well-being and mental well-being improved over the period, and loneliness declined. So there was overall a positive result. This was despite the pandemic, and it's important to bear in mind that the results were taken place during the follow-up took place during the pandemic. And it's important, social prescribing was seen as important to filling gaps in existing services. So young people really appreciated the immediacy of support. So the fact that link workers were able to support them very quickly, especially while they were waiting to be seen by statutory mental health services like CAMS, for example. So what are the key reflections for the future of social prescribing? So one is that the role of the link workers can be complex. So they have to liaise with many different support providers, like schools, for example, and parents and carers. So the role is quite complex and often is a coordinating role as well. So the voice of young people is also important, and something that some more needs to be done on the involvement of young people in design and development, evaluation of social prescribing would be quite useful to improve the effectiveness and results of the service. The ethnicity of respondents, as I said, was mainly white British. So there's a lack of studies on ethnicity across the social prescribing, even for adults. So I think more needs to be done around this and widening participation. And finally, I would like to say a word about the role of social prescribing in a post-pandemic world, where mental health, lack of social interaction, a lack of access to education have probably left a lot of scars. So social prescribing can really help young people to deal with and to tackle these issues. And I'll stop there, and thank you very much for listening.
Wonderful. Thank you so much, Marcello. And we are going to move to our final presentation, which is from the fantastic Sheffield Futures project in Sheffield, surprise, surprise, where there's been a link worker project there for a few years. It's actually one of the sites that Marcello evaluated, and they've now made brilliant links with their primary care networks. So their team of one link worker has expanded to 4 or 5 now. So it's a really great example. And we're going to hear from Christos, Louca, who was a link worker last year and is now coordinating the whole scheme, and 3 of the young people who he helped through that scheme. And it's a film, I just want to put in a quick word for, it's a film made by a young volunteer for Street Games. His name is Aladdin. He's an early career videographer. I think this will be his first ever broadcast. So so we're very grateful to Aladdin for producing this film.
Hi, I'm Layla. I'm 23. I'm having a gap year at the moment.
Yeah, hi, I'm Ryan. I used to be part of the social prescribing service with Christos. He helped me out for a few months, and I still join events and meetings every now and then as well.
I'm Evie. I'm 19 and I live in Hillsborough.
I'm Christos. I'm the social prescribing coordinator at Sheffield Futures, and previously the social prescribing link worker for door 43 of Sheffield Futures.
I was referred by the Sheffield IAPT team during therapy. So I think there were times that I found it hard to because a lot of my friends had moved from when I finished university. So I found this as a way to meet new people and so on. And Christos helped a lot with finding activities and with the social prescribing and wellbeing cafe and things to take part in.
I was with my psychiatrist for mental health and NHS, and it was more of employment is what my doctor said to me. But then when I came to door 43, I think there was an age bracket, and I was maybe just over something. So then I went through the social prescribing group instead.
I met Christos at Wellbeing Cafe already, and I feel like a lot of it started with just like talking to him about what I wanted to do in cafe, and then we did stuff like yoga. We went to the board game cafe. He came to a like interview, sort of like volunteering interview with me. We did some meditation. It didn't go very well, but it was good to try out different things. Yeah.
And then there was an interest in libraries. So Christos helped me walk around different libraries, and it was seeing if they were taking on volunteers and if there was any a contact. So I was interested in working in libraries at that point, and he's called Daryl, to get more information on if that's something I'd actually like to do in the future.
So I went to a few football activities. We tried to find something with music. But I think the main thing was the Wellbeing Cafe that got me to meet new people. Before the lockdown, I was attending every week pretty much as well, and I guess it really helped in that sense.
That's a great thing about social prescribing, that try and identify interests from young people and give them a go and have that time to be able to try something. But if it's not necessarily suitable, like the meditation for yourself, Evie, or the football groups, some of the football groups we went to for Ryan, in terms of maybe location or the actual activity itself not being necessarily suitable, we can then look at alternative options and try and engage in something else, and really having that time to invest in young people and go along and offer direct support to a service to try and overcome various barriers, I think is, it's just a great thing about social prescribing, in my opinion.
I think not from your point of view. I think the activities I went through, sort of the location and variety that sort of suited me wasn't there, but then that's not a criticism of your service. I suppose it's more of what's available. Yeah, I think what we got, we kind of made do with it, but I think there could have been more activities around Sheffield and so on.
Yeah, just that I think that it would have been nice to know what other people were doing, to see if I was interested in anything they were doing, or if, because I don't know everything and I don't know what I like, but to know that someone else likes something else, and I think actually it's quite a nice idea that I'd enjoy. I think I could have benefited from that. I think you should do social prescribing because it's easy, and the people you work with help you and motivate you to join in new things and engage in activities.
I think you should do social prescribing because it's a way to meet new people and to find out new services following your interests, and it's a sort of good way to follow up with what you've took an interest in.
I think the real key thing for me and the benefit of social prescribing is being able to provide that direct support to a service. It may be a case of going along to a service, not necessarily to engage with an activity or the service itself. It may be just to familiarise with an environment or familiarise yourself with staff members delivering the provision.
Thank you all so much. Take care, go safe.
So we've got lots of questions in the chat, some of which we're not going to be able to tackle everything today, but we will respond as part of the ongoing resource development for the website for anything that doesn't get picked up. And there will be basically a full recording of today's session and the answers. But Paul, we talked about trying to take away 3 words that describe for the presenters what they have taken away from this session. I'm not sure if we want to start with that or some specific questions, because we've got basically questions for everybody that I can see. What do people think? Should we start with the specific questions from the audience? Yeah. Yes, okay, then let's start with Celia. Celia, a quite specific question. How does Parents First differ from more well-known services like things like Home Start?
I think Home Start programs do differ quite a lot across the country. some programs that we operate actually link up with Home Start programs, in that we focus specifically around early prevention, working closely with maternity units, perinatal mental health services to engage with vulnerable pregnant women as early as possible in the pregnancy. So there's a very strong link with NHS services, which is probably one of the key differences. So it's really important that Home Start and initiatives like Parents First do operate in partnership. It works very well in Essex because when we start withdrawing from supporting parents and they still need additional support that's more relevant through Home Start activities and a lot of other different organisations as well, that we can then link them up with ongoing support. So it's about working in partnership. But I think the key difference is that there's really close embedded relationships with NHS frontline professionals who make referrals at the beginning of pregnancy.
Thanks, Celia. Paul, I've got a question here for Christos. Shall I ask this and then I'll hand over to you for a third question?
Go for it.
So we have a GP called Daisy Robinson who's based in Devon in a rural practice. And Christos, she's asking what advice can you offer about setting up a service for children and young people, specifically in a rural area?
I think the key is obviously identifying that need for that support, and what we're looking to do to kind of support all the work that we have got ongoing for social prescribing with children and young people is linking in specifically with the schools in nearby areas. I think that's a real key way for us to identify that need that I initially mentioned, and exploring ways to potentially supplement the provision and the wellbeing support that is already ongoing within these schools. So I would suggest if there's any kind of nearby schools in the area, it's a great way to then, like I said, identify that need. But of course, it also depends on those kind of within the area that are potentially able to deliver such provision, such as social prescribing. So I guess without knowing the area specifically, it's difficult to say, but knowing that obviously there'll be schools around would probably be the first port of call for myself, and that's where we are looking to expand our delivery as well. Of course, you would expect great numbers of young people to be attending these schools and maybe not all necessarily attending GP surgeries. So again, it just kind of provides that backup for exploring the need and demand through those areas.
I would add as well, Daisy, it might be worth finding out who your NHS England facilitator is for social prescribing, because they'll often have an overview of projects that are developing and potential collaborators. Paul, would you add anything?
I think that's a great first step. That's an absolutely great first step, and maybe just join the Social Prescribing Youth Network as well if you aren't already. That's a great way of connecting with people both geographically in your area and also who are maybe starting out with that kind of work. Shall I move on to our next question, Joe? So this one is from, I believe her name's Shari, and who's a children's A&E consultant, and who says, first of all, this has just got to happen, which is great. Thank you for your positivity there. Wondering if this kind of work, social prescribing, is embedded anywhere in secondary care, which is quite a broad question. So I'm going to go to Tiffany and Dennie first. Is any examples of working with secondary care as in hospitals? Don't forget to unmute yourselves. Thank you.
Hi, yes. Through the Lullaby Project, we primarily work with mothers in healthcare settings. That could range from public hospitals to smaller clinics. We have worked within NICU settings as well, and a range of secondary health providers. So looking at mental health, we're now going, at least in New York, working with a group called the Motherhood Center that really focuses on postpartum depression and the interventions that music and the role that music can play in supporting and really combating postpartum depression and supporting that bond between parent and child. We do work in a range of settings, and that tends to be very flexible with our partners globally. They do have the option of deciding what role this project can play within their community, so how it can best serve the families that they're working with.
Great, thank you, Tiffany, for that. Marcello, have you come across any examples?
Not specifically with for young people. I was just thinking it through just now. Not for adults. Yes, there are a few. There's Homerton Hospital in London, for example, who did some work, but not specifically for young people or children and young people. Yeah.
Aware of I think it was quite short-lived, a pilot project that took place in Birmingham on the oncology ward, I believe, for children and young people, where they were taking it was for young people who were shortly to be discharged from hospital after their treatment, and they had a link worker going in to help them connect with social activities and things that might be of interest as they were coming out of having been in hospital for several months in some cases. But I'll try and find a link for that and share it with the group.
I'd add, this is where often language becomes a barrier, because there's been lots of activities through a creative health agenda in hospitals with regard to the use of music. Alder Hay in Liverpool, the Romantic Children's Hospital in Great Ormond Street, where they have musicians on tap to support the children that are often long-term stay. But most importantly, it impacts on the wider family and siblings. And I think it's quite indicative of how social prescribing has that ripple effect, and you in effect get more bang for your buck in that investment because it supports that wider family. But also, and we can share this link, there is a document called Instrumental for Health, which looks at how by having musicians on the wards, it's impacted on staff as well. And given where we're at with the pandemic and that everyone's batteries are very low, I don't think we can underestimate how that ripple effect can impact on staff to keep them going. So yeah, we can share that link as well. I've got a question for Pamela from Sam Henderson Palmer.
Yep.
Pam, is there a theory of change for loneliness that could help address how social prescribing might impact and be measured?
Yes, I think that we would expect, the development of more trusting relationships, the idea that you'd be fitting into communities and being more accepted by communities. We would expect there to be reductions in loneliness, because loneliness works the same across all age groups. It's the same issue. The only thing that would be different would maybe be differences for primary school age children, where the focus is less on the quality of a relationship and more actually on physical proximity. So just actually having chance to be with other people in a playing situation is usually simply what they need, as well as an understanding from adults as well. So there is a theory of change. But it's not necessarily an explicit one that's written down somewhere.
Paul, any more questions from you? I have a few more.
Yeah, go for it. I was just checking the Slido questions. I was distracted.
So a question from Bethany Brown. How does social prescribing differ from existing forms of work in reducing loneliness? So I'll throw that out, but Pamela, you might want to start.
Yeah, I mean, it's worth knowing that actually when you look at interventions for children and adolescents who report loneliness, actually there is nothing out there that is systematically being evaluated. We've just done a big review of all the interventions that have got an evidence around them. None of them are specifically targeting lonely children. They're targeting children who adults think are lonely. Which of course is a major issue, because you might see change in loneliness in those interventions, but actually these kids weren't lonely to start with anyway, so it wasn't an issue. So that's where we're starting from, is really not having anything available that's been systematically evaluated. So, has anybody got a feeling from the work that they're doing that they are actually impacting those feelings of connection?
Can I add to Pamela's points? Because there are a few things actually. One is that in the next session there is a somebody's presenting systematic review on loneliness, and so that might be interesting to some of you to attend. It's Dragana Vidovic, is a presenter. The other point is about loneliness and what the implications of loneliness. So for example, I think I'm thinking about the elderly here, but actually it probably applies to young people too. So the response that can be given to a young person is that maybe the young person cannot just go to a social setting straight away if they feel lonely. So then again, the social prescribing can provide quite a useful instrument in a sense, because you have a link worker, you can have one-to-one interaction. So and those issues of loneliness can be uncovered, if you like, unpacked, and then slowly the person can be then referred and helped and supported into a more group setting, which probably at the end of the day will help those people, that person, the young person, with the loneliness and create social support systems and so on. So I mean, I just thought that actually social prescribing can help with both the one-to-one and also the group setting.
Yeah. I've got another question here as well from Julie McCarthy, which I'm going to change slightly because I wanted to open it out to other presenters. So Julie was interested in how you frame social prescribing with the focus around loneliness and isolation with children and young people, when admitting that you're lonely is a bit of a taboo in terms of how many friends you've got, etc. on Facebook. And I wondered, and I'm thinking explicitly in relation to either Celia or Dennie or Tiffany, about some of the advantages of the work that you do in terms of providing a vehicle for early engagement, because it's presented in a different way in relation to the songwriting and the lullabies. Are there some distinct advantages of approaching social prescribing and these types of interventions in the way that you do?
I think what's struck me so much when I was listening to the other presenters, Jo, is how much synergy there is across these projects. For example, because we work so closely with midwives, when they will do their first assessment with a pregnant mum, if this is a teenage mum that they can see is vulnerable, they can link them up with us. Then we also work closely in Essex, for example, in the Basildon Youth Hub. And so we can link, but through peer support, you can link those teenagers in with the Youth Hub, but it also then links up with our program and the peer-to-peer, the one-to-one and the group stuff that goes alongside the Youth Hubs. There's so much cross-fertilization that can go on here, and certainly loads of evidence that it reduces social isolation in really vulnerable teenage parents.
Tiffany,
would also say from our experience in Lullaby that coming in on the footing of music and being a songwriter carries with it a sense of agency, and without the issues of I'm alone, I'm isolated by being a young mom. So they enter on the music and leave on the connection. But I think it speaks to the need for programs to actually build into delivery the mechanisms that will keep people connected once the program or the prescription is over. So we have work to do in that respect.
That's right. And if I just may add, as Dennie said, we're centering humanity in this work. What we are focusing on are the strengths and creativity that families have to offer and bring to these experiences. And so while these families might be vulnerable, experiencing trauma, experiencing a range of inequalities, they are bringing their best foot forward and recognizing that through the process. And that is really our goal through this work. And that's what excites the families. That's what excites the practitioners who are supporting this work on the ground as well. And we've had healthcare workers participate in writing their own songs as part of the process. I will also say, you know, in the US, we do not have social prescribing. It's a lovely thought. We're excited to be here. But there are challenges around recruitment. As exciting as this experience is for families and our community members, you know, we don't really have staff capacity all the time to get the word out, to let parents know. We wish we had link workers and folks like Christos who could share this message out more broadly and ensure that we have folks in the room who can participate. So, you know, that's a long-term goal that we hope to see pan out in the near future.
Thanks, Tiffany. That's absolutely wonderful note to an optimistic note to draw us towards a close. And I'm really sorry to those that we didn't get to field your questions. As Joe said, we will try to do that. I believe we can save the chat and we'll pick up all the questions and try to produce a Q&A sheet after this that will be distributed to everybody that attended. So just going to wrap up, I'm going to attempt to do a final last screen share of the Slido questions, which are were unrehearsed, and we asked you the same question at the start and end about your confidence in social prescribing for children, young people, maternity, early years, and drum roll please, the answers to the first question that I'm going to try. So this was when we asked you first, and I'm hoping you can see this. Can you see that? So 31% said not at all, and 47% said a little, and 22% said quite. So bear that in mind. And we've asked you again at the end of the session, we're looking for improvement. We don't know what it's going to be, but the answers to when we asked you the next time, there we go. Look, 0% not at all, and a big increase in quite confident about your knowledge. So I think that's a big tick to all of you guys. Thank you so much for all of our presenters. We did ask you a question in the middle, just to give us 2 words on what you thought the impact of social prescribing for children and young people might be. And there we go. We've got a little word cloud with connection and sense making coming out as the top most popular words, but a lot of other connection, community, resilience in there as well. So that does bring us to a close. I want to finish by saying a huge thank you to all of you for coming, to our wonderful presenters and panelists, and do go enjoy the rest of the conference. There is, when you get to the networking zone, if you do go there after you've had a bit of a break and a lunch, there is a table set up there for maternity, early years, children, young people, social prescribing. So do go, and if you want to carry on the chat from there, do go there and have a good time talking to each other. Joe, over to you. Any final words?
No, just that please do access the resource sheets and do engage with basically your local social prescribing networks if you're not already linked in. There are 12 NHS England coordinators who straddle all components of the prescribing system. So whether you're in the GCSE, you're part of a primary care network, primary or secondary care, there are lots of developments happening. So now is the time to connect.
Fantastic. Thank you very much, everybody. Enjoy the rest of your day.
Thank you.